Hello and welcome to the Pediatric Dermatology Research Alliance special series, Emerging Methods of Action in the Treatment of Moderate to Severe Alopecia Areata in Children. This is part 2 of 6, The Science. A special thanks to Pfizer for supporting this program with a grant. The program chairs who helped develop this Alopecia Areata program are Dr. Leslie Costello-Socio, Assistant Professor of Dermatology and Pediatrics at the University of Pennsylvania Perelman School of Medicine, and Director of Research in the Section of Dermatology at Children's Hospital of Philadelphia. Also, Dr. Britt Craiglow, Adjunct Associate Professor of Dermatology at Yale, and she also sees patients in private practice in Fairfield, Connecticut. With that, I would like to turn it over to Dr. Costello-Socio to introduce Dr. John O'Shea.
Hi, good evening, everyone. So glad to have everyone back for part 2 of the Alopecia Areata education series. I'm really honored to introduce Dr. John O'Shea to start to introduce the science of JAKs and of cytokines that are related to the immunology of alopecia areata. As many of you know, Dr. O'Shea is the scientific director of NIAMS, and he is really one of the periarchs of cytokines and JAKs and tyrosine kinases. He is well known for his mentoring, which is really important to me, as well as, obviously scientifically, well published with over 200 articles and so many honors. And we learned tonight he's a huge guitar enthusiast. And he actually plays in a rock band with Dr. Francis Collins, which is pretty amazing. So I'm thrilled to hear his talk and learn about JAK inhibitors.
Thanks very much, Leslie. So my job is to talk about JAK inhibitors for the next 15 or 20 minutes or so. My disclosures are shown here. The NIH and I have a patent related to JAK inhibitors, but again, if others of you have heard my talk, you can be relieved that I've made literally hundreds of dollars over the years. And I also have a collaboration with Pfizer that just ended this year, but we've collaborated for probably a quarter century or so. And also, I'll be talking about off-label use of drugs, and I'll include references where appropriate. So you've probably seen slides like this many times, and it's not for alopecia areata per se, but most autoimmune diseases are like this. You have this confusing array of all sorts of cytokines, sort of in a bewildering sort of pattern here. But I wanted to point out a couple of things on this slide, and that is that there are probably about 200 or so things in the human genome that you can call cytokines, and they're obviously critical for host defense, immunoregulation, but from your perspective, autoimmunity. But cytokines also do a bunch of other things, including they're important from hematopoiesis, tissue repair, homeostasis, growth of the individuals, and metabolism. And so one thing, of course, then now that we have drugs available is how do you keep track of these things if you don't spend all day, every day worrying about cytokines, and why are they important? And just a clue, as I'll get to in a moment, on this particular slide, the JAK-dependent cytokines are illustrated, and other cytokines have different colors, but that's going to be sort of answering these questions. So the way I put cytokines together is to think about them in terms of the receptors that they bind. So there's 7 major classes of cytokine receptors shown here, starting with type 1, type 2 cytokine receptors, but also TNF receptors, IL-1 related receptors, IL-17 receptors. Some cytokines bind receptor tyrosine kinases. There's a number of TGF-beta receptors, and I've included here chemokine receptors. And we learned about these cytokines and receptors sort of during the molecular biology revolution of the 1980s and 1990s. And then in the 90s, we also learned about the ability to target all of these cytokines through biologics. And I've given a bunch of examples for the different categories shown here. These, of course, are not biologics, but I just included these as targeted therapies for your consideration. But what became clear with the use of biologics is, as impressive as they were and as revolutionary in many respects as they were many patients had incomplete responses, or complete remission was rare. And so we considered, we and others considered other options, and that was thinking about how cytokines signal and can you target molecules intracellularly, therapeutically, and have them be efficacious and safe. And the field of cytokine signaling sort of blew apart in the early 90s, especially with the work of Sandra Pellegrini and George Stark, who were making cells that were mutant cells that lacked responses to interferons. And the big breakthrough came when they showed that they could correct the defects in one of the cell lines by expressing this tyrosine kinase. It's actually TYK2. It's got I see a typo here, tyrosine kinase 2, but a sort of a vague sounding name, and that restored interferon signaling. And then the rest of this picture came together pretty quickly with the discovery of STAT family transcription factors by the Darnell lab, using promoters from interferon-inducible genes as bait for DNA binding proteins, and in its case, it was the STATs. So I just wanted to illustrate quickly to get in your mind that some cytokines use JAKs and STATs, but not all of those 200 cytokines. So cytokines like IL-1, TNF, IL-17, etc., don't use JAKs, and so that will be relevant for discussion more really about safety, about efficacy rather than about safety rather than the efficacy. As we'll get to, targeting JAKs at present, the first generation JAKs target 57 or so cytokines, but not all cytokines. And that's depicted here. But we learned a lot about the roles of JAKs and STATs in these mutant cell lines that I was referring to before. But at the time, we really didn't understand exactly what would happen when you targeted JAKs in vivo. And that, you might have guessed, that would come from making knockout mice and this sort of thing. But that's not how it unfolded. The way it unfolded was shown on this slide here. So when we cloned JAK3, we cloned it out of immune cells. And I had been working previously in a lab next to Warren Leonard, shown here. And Warren Leonard was the person who cloned the IL-2 receptor alpha chain. And in putting together the understanding of the complete IL-2 receptor, Warren Leonard recognized that the shared receptor subunit for this family, IL-2, 479, 15, 21, IL-2 receptor gamma chain, is the basis of X-linked severe combined immunodeficiency. And because we had cloned JAK3 out of immune cells, we were thinking that might be a possibility that JAK3 associated with the common gamma chain, and that turned out to be the case. We did that with Warren Leonard. And then when he found that mutations of the common gamma chain resulted in X-linked severe combined immunodeficiency, we predicted that, well, perhaps maybe mutations of JAK3 would phenocopy mutations of XGID. And people like Gigi Notarangelo and Rebecca Buckley were following this field closely and, in fact, identified such patients. And we collaborated with Gigi Fabio Candati and Rebecca Buckley to identify the first individuals who had mutations of JAK3. Now, in that paper, we made this bold claim that if you targeted JAKs, you'd get a new class of immunosuppressive molecules. But in fact, like in a lot of things in science, we knew that this was the case about 2 years before. I had met Paul Chingalian at Pfizer, and we had started collaborating on this project to see if this, in fact, was a feasible concept. And this is where we are now, of course, that there are 9 approved JAK inhibitors listed here. Ruxolitinib was the first JAK inhibitor approved for an orphan disease, myeloproliferative neoplasms, and now acute GVHD. Tofacitinib is the Pfizer drug and is approved for rheumatoid arthritis, psoriatic arthritis, juvenile arthritis, and ulcerative colitis. The next approved JAK inhibitor is baricitinib, which was approved for rheumatoid arthritis, atopic dermatitis in Europe, And now COVID-19, and maybe we can discuss this a bit of a surprise. The baricitinib being useful in this context. Also, several other JAK inhibitors, and I'll have a bit more to say about the selective JAK inhibitors like upadacitinib, filgotinib, etc. But of course, we can't forget the JAK inhibitor for dogs, oclacitinib, approved for treatment with atopic dermatitis. And I would say if any of you, your dogs are on JAK inhibitors, please do send me pictures, preferably before and after. It's always heartwarming to see dogs smiling and wagging their tails after being on JAK inhibitors. A number of other trials are ongoing, and I've listed them here. I won't go through all of the details here, but just again, a wide variety of indications, including inherited interferonopathies, including Down syndrome and other autoinflammatory diseases, and a wide number of other indications. Just quickly, I wanted to touch on this point here. This was at last year's ACR meeting, and the efficacy of JAK inhibitors are clear in rheumatoid arthritis. So the great debate at that time was, well, maybe we shouldn't wait for JAK inhibitors to start JAK inhibitors after we use biologics. Maybe we should consider using JAK inhibitors first. And there are data showing that JAK inhibitors are effective when biologics don't work. They have a quicker onset of action compared to biologics, especially in terms of pain, which I think is a particularly interesting part of this these findings. They're convenient because they're oral. Generics are coming soon. They have a short half-life, which has advantages in a number of situations. And at the time when they're making this sort of argument, it was sort of put forth that JAK inhibitors, the safety of JAK inhibitors were really equivalent to biologics, except for herpes zoster. But I'll have more to say about that in just a few seconds. And that is just to review the adverse events with JAK inhibitors. And as we would have predicted from, making this prediction in patients who had severe combined immunodeficiency, infections are seen in patients on JAK inhibitors. But maybe a surprise is that generally infections are comparable to what you see with biologics, again, except for herpes zoster. You see cytopenias with first-generation JAK inhibitors. That's because they also target JAK2, which is used for signaling by a number of hematopoietic cytokines. You see increased lipids, and that's presumably related to IL-6 inhibition or possibly leptin as well. That's some debate as to exactly how much you're affecting cardiovascular risk. Thromboembolic events have been noted, venous thrombosis and pulmonary embolism, and again, exactly why that is may be related to TPO, maybe JAK2, again, not totally clear. You see increased creatinine, increased transaminases, GI perforation, again, mechanism largely unclear. When the FDA was first reviewing these drugs, they were concerned about cancer. Obviously, if you think about blocking things like interferon gamma, et cetera, and blocking T cells in general, one would raise that concern. They issued a report earlier this year in February, and then the quote is here that there's a higher occurrence of serious heart-related events in cancer in RA patients treated with tofacitinib compared to patients with a TNF inhibitor. So that's sort of the key point. The trial has not been published yet. They're seeing all the usual details of getting into the gritty details of a paper such as this. But it's worthwhile pointing out that these patients were on TNF inhibitors, and so we actually in this don't really know sort of the background occurrence of all of these adverse events here. So stay tuned for that. This will be an important trial to keep your eyes open for. Okay, just going back to JAK structure, how they got their names. They have a kinase domain and a kinase-like domain named after the Roman god Janus, shown here. There are 4 JAKs, JAK1, JAK2, JAK3, and TYK2. Again, TYK2 is a member of the Janus kinase family. It's structurally the same as the other JAKs. I'll come back to this kinase-like domain in a moment. And then just going through after our report of the JAK3 deficient patients, as you would imagine, all of the knockouts were generated rather quickly. JAK3 knockouts were made, and they too have combined immunodeficiency. TYK2 knockouts have viral susceptibility. Patients, human patients with TYK2 loss of function mutations have been identified, and they too have infection. There's a human loss of function polymorphism, relatively common, that's associated with decreased risk of autoimmunity and impaired signaling by interferons IL-10, IL-12, IL-23. JAK1 knockout is perinatally lethal in mice and was associated with combined immunodeficiency. I believe there's one human that has been described with JAK1 loss of function mutations, and you'll see why that might be a rare event. That patient had multiple infections, including herpes zoster, atypical mycobacterial infection, and early onset bladder cancer. There is, I think, 2 patients described with JAK1 gain of function mutations, and that those children have autoinflammatory disease. JAK2 knockout is embryonically lethal because of defective hematopoiesis. So again, the scorecard here, and again, it's busy, but the point is actually a simple one. And then that is that JAK1 is important. Of the 57 cytokines that use the JAK-STAT pathway, JAK1 is important for a large number of these cytokines. JAK2 also equally large number shown here. JAK3 really is important for only the cytokines as best we know, IL-2, 4, 7, 9, 15, and 21. TYK2 encompasses a smaller proportion of cytokines, but bearing in mind that there are 14 interferon alphas, etc. But again, a restricted number of cytokines compared to JAK1 and JAK2. So here's just sort of to summarize these findings is that the first generation JAK inhibitors inhibited, again, have the capacity to inhibit a large number of cytokines, potentially almost all of the 57 cytokines. When you get to selective JAK1 inhibitors and selective TYK2 inhibitors, you're now inhibiting a smaller spectrum of cytokines. There are selective JAK2 inhibitors for oncological indications, and then there is a selective JAK3 inhibitor. And again, I'm not going to go through all the details of this, but just to show you the names again, JAK1 selective inhibitors approved for rheumatoid arthritis, multiple ongoing trials. Filgotinib, a selective JAK1 inhibitor, approved in Europe, but not in the United States. I should point out that upadacitinib, patients on upadacitinib can have anemia. So again, it's selective-ish, maybe would be the word. Also, itacitinib and abrocitinib, the Pfizer compound with ongoing trials in atopic derm, psoriasis. There are TYK2 selective inhibitors. Deucravacitinib is the BMS compound. It's being tested in psoriasis, Crohn's, SLE, and this targets the kinase-like domain. And I'll repeat that in just a moment. Beprocitinib is a TYK2 JAK1 inhibitor from Pfizer with ongoing trials, including alopecia areata, and another TYK2 selective inhibitor from Pfizer doesn't have a generic name yet. So just getting back to this point about targeting the kinase-like domain. So most JAK inhibitors are competitive ATP antagonists. So this is the catalytic domain of JAK3, and you can see ATP and tofacitinib overlaid in this cleft. And this is what the JAK kinase-like domain interacting with pseudokinase domain looks like. But I just sort of remind you that the deucravacitinib is actually binding the pseudokinase domain. So in principle, might have an advantage in terms of the specificity. There are combined inhibitors coming along. Ritlecitinib is actually a JAK3 TEC family kinase inhibitor. So it inhibits these TEC family kinases, ITK, TEC, BTK, RLK, BMX. BTK, as you know, is the basis of X-linked agammaglobulinemia. So in principle, ritlecitinib could inhibit cytokine signaling, but also BCR and TCR signaling. Ongoing trials listed here and some reported efficacy, but basically no really unexpected adverse events even though it inhibits JAK3, but also other signaling pathways. Gusticitinib is a JAK-SYK inhibitor, and SYK is important for B-cell receptor signaling, Fc receptor signaling, integrin signaling. Gusticitinib has been studied in phase 2 trials in atopic dermatitis, and those papers have been published. Okay, so that's the quick picture of my introduction to JAK inhibitors with, again, JAK inhibitors misspelled. Sorry about that. But lots of questions, and I'll just put these up and maybe we can return to these later. I think really the big question relates to efficacy and which cytokines are being inhibited in what cells, what phase of the disease, and then, of course, what does that mean in terms of how you're going to treat patients? Really, what's the best dose to use? Do we have the best dose for induction and maintenance? In terms of measuring specificity, how do we really do that? There's a variety of assays you could use to think about specificity. But really, what it comes down to is if a patient is on a JAK inhibitor, do you see anemia, et cetera, and other things? How do we use JAK inhibitors with other drugs? I alluded to that in the ACR great debate. Do we use biologics first, and if they fail, then switch to JAK inhibitors? Do we use JAK inhibitors first and then put patients on maintenance phase? What other drugs are safely used? All of which we know some of this, but we need to know much more. Going to the issue of COVID, the fact that baricitinib is used and it's efficacious in COVID patients makes one think that, again, we should be thinking more about dose of JAK inhibitors and possibly intravenous, short-acting, rapid, acting JAK inhibitors. And I think I will stop right there and put these references up. And again, if you feel the need to review the JAK-STAT pathway quickly, we have this handy little scorecard right here. And if any of you have to give this talk, just send me a note, and I'm happy to send my slides along the way.
Thank you so much, Dr. O'Shea. That was so great. And I think there are some questions that have come in, but we will address those a little bit later after Dr. Jabbari speaks. So we're going to move now from sort of this more broad overview to, now I think you can see me. Okay, good. We're going to move from this really excellent overview of JAK inhibitors, and then we're going to talk about, or Dr. Jabbari is going to tell us about the rationale for their use in alopecia areata. So Dr. Jabbari, we're really honored to have him with us tonight. He's an associate professor of dermatology at the University of Iowa, where he is a jack of all trades. He runs a basic science laboratory. He supervises the resident-run hair clinic, and he's the PI for their alopecia areata registry there. He's done really groundbreaking work in helping us to understand the pathways, the basic science pathways in alopecia areata, which really has, started to pave the way for more reliably effective therapies for our patients. And he at home has 5 kids. We just learned, 3 kids under 5. So he's busy at work and he's busy at home. And I think we're all going to really enjoy his talk tonight.
So today I'm going to be talking about alopecia areata pathogenesis and specifically some of the preclinical rationale for using JAK inhibitors. And a lot of this comes from the mouse models that we use to study the disease. My conflicts of interest arise mostly from doing some of this preclinical work for some companies, as well as serving as a site PI for some of the clinical trials. I will be mentioning off-label use of JAK inhibitors, and I will be talking about animal models of the disease, and all the research that I'm going to be talking about using these animal models complies with all of the guidelines and protocols that are appropriate. So many of us here see patients with alopecia areata, but just as a review, these patients often present with circular patches of hair loss, as you can see here on the upper left. This often affects the scalp, but can really affect any hair-bearing surface, as you can see here on the bottom left, affecting this individual's kind of beard area. disease can be multifocal, and sometimes these areas can grow, coalesce, and involve not only the entire scalp, but the entire body surface area. In some cases, you get some interesting patterns. This is called the ophiasis pattern that involves the temporal, parietal, and occipital scalp. And it's important to note that the majority of patients that have alopecia areata get the disease at some point before the age of 20. So just to round up the epidemiology, males and females seem to get the disease at about an equal rate. There might be a slight female predominance. There's a 2% lifetime risk, so approximately 7 million cases in the U.S. As already mentioned, most patients that get the disease will have their first episode when they're younger than 20 years old. As I'm sure you guys have talked about in earlier sessions, it has significant impacts on the quality of life and self-esteem of these individuals, can be associated with other autoimmune diseases, and historically has been treated with broad, local, or systemic immunosuppressants that really haven't worked particularly well, or that have potential for worrisome side effects if used in the long term. And the etiology for the disease is largely unknown, despite the fact that the disease has been well known in the medical literature for a very long time. Up here on the upper right is a illustration from a medical textbook from the 1800s that seems to be depicting alopecia areata. And down here on the bottom right is what's called the Ebers papyrus. I think that's how you pronounce it, which has been dated back to 1500 BCE and describes spotted baldness and the kind of interesting treatments that were used at that time for the disease. But we know now that there are some genetic associations, in part due to the work of Lynn Pechikova and Angela Cristiano. And there's this question of whether stress is related to the disease or not. And I think that's somewhat controversial. But if we're thinking about alopecia areata and if we take a look at what it looks like under the microscope, we see in individuals with the disease, their hair follicles are surrounded, and usually this infiltrate that we see under the microscope is usually centered around the peribulbar or the bulb of the hair follicle. Now, this is in contrast to the normal hair follicle in the growth phase, where there's really a posse-immune environment here. And one important point that I'm not going to talk about a lot today, but is important to mention, is this concept of immune privilege of the hair follicle. And that really describes the low level of expression of MHC class 1 that's present on the hair follicular epithelium normally. However, in alopecia areata, we see an upregulation of this MHC class 1 and a more pro-inflammatory kind of environment. And if you'll remember, MHC class 1 is it's the kind of complex that allows the immune system to survey what the contents of the cell is. So normal antigen hair follicles are usually somewhat invisible to the immune system, whereas in alopecia areata, it's much more readily interrogated by the immune system. And so most of the studies I'm going to be talking about today make use of the C3H-HEJ mouse model of alopecia areata. This is a pretty common lab strain of mouse. And it was observed a couple of decades ago now that these mice spontaneously develop disease. It's a relatively low rate, about 10 to 20% of mice, and it takes about a year for them to develop the disease. But it shares many of the features of alopecia areata and has been very informative as the pathogenesis of the disease. So just as a framework for the rest of what we're talking about, I just want to start off by talking about some large unbiased studies that were done to determine what are the major signaling pathways or the major cell signatures that are present not only in the disease in people, but also in the mouse model. So what was done was biopsies were taken from AA patients and normal control patients, and the same was done for the mice. A skin sample was taken from an affected mouse or affected mice and compared to that of unaffected mice. And these samples were then interrogated using microarray technology to ask which genes or pathways are different in alopecia areata when compared with normal samples. And whenever you do a microarray or an RNA-seq type study, you get a list of upregulated and downregulated genes that really look like basically like an alphabet soup, but it becomes really helpful when you can start putting these into categories. So when this was done, there were three major pathways or profiles that came up. The first was CD8 T cells or CD8 T cell activity. The second was the interferon pathway, which you've already heard a little bit about. And the last one was the common gamma chain cytokine pathway. And again, we'll hit the highlights of each of these for the next 10 minutes or so. So first, talking about the T cells, and this kind of reminds us of studies that were done in 2005, where people were interested in figuring out what are the critical cell types that can induce disease, or what cell types are sufficient to induce disease. And what the McElwee group did was they took mice that had already developed disease spontaneously, harvested the skin-draining lymph nodes, and injected those into recipient mice to ask whether those cells could induce disease in those mice. And when they took lymph nodes from an AA mouse, they were able to induce disease in the majority of those recipient mice, whether that be a localized disease or more systemic disease. For the purposes of today, it really doesn't matter which one, but they were able to induce disease with these lymph node cells. And this contrasted with that of lymph nodes that were derived from mice that didn't already have alopecia areata. Then the authors went on to specifically sort out the CD8 T cell population and ask the same question. If they injected those into recipient mice, could they induce disease? And indeed they could in all of the mice that they that received the cells. And then they asked if CD4 T cells could do the same, and not quite as robust as the CD8 T cell population, but indeed they could get cells, or they could get mice to exhibit disease after they've received CD4 cells. So then in thinking about these T cell populations, there was a study that came out from Lynn Pechikova and the Cristiano lab looking at what genes were associated with the disease. And they ran what's called a large genome-wide association study, and they found places in the genome that were associated with alopecia areata. And this is a Manhattan plot here. On the x-axis is the position in the genome marked by chromosomes, and on the y-axis is a measure of statistical significance. And they found 8 loci, and these loci were all closely associated with genes in that same region. And the authors of this paper paid particular attention to the second highest, or the second most statistically significant locus, which was found close to 2 genes, the ULBP genes, ULBP3 and ULBP6. Now, these genes are ligands for a receptor called NKG2D. And NKG2D is found on T cells and other cell types. And the authors of this paper then went on to look at expression of ULBP3 in hair follicles in patients with alopecia areata, and found, as you can see here on the right, marked in red, high expression of ULBP3 in those patients, but not in normal control patients that didn't have alopecia areata. And then they went on to describe that NKG2D was expressed in cells that made up the immune infiltrate, or that swarm of bees, so to speak, around the bulb, and they were found on CD8 T cells. And this also held true for the mouse model. So these are flow cytometry plots. On the x-axis is CD8, on the y-axis is NKG2D. And when you look into mice that have alopecia areata, you can find a pretty robust population in the skin or in the skin-draining lymph nodes of these NKG2D expressing CD8 T cells. And these are largely absent from those mice that don't have the disease. So then to take it one step further, it was asked whether those CD8 T cells that express NKG2D were sufficient to induce disease. So taking lymph node cells from mice that had alopecia areata and specifically sorting out that population and injecting them into recipient mice led to those mice developing disease. And in contrast, CD8 T cells from the same lymph nodes that didn't express that NKG2D receptor didn't cause those recipient mice to develop disease. So now we know CD8 T cells are able to transfer disease, and CD4 T cells from alopecia areata mice are able to transfer disease. So how do these two cell types, how do they coordinate with each other to cause AA? Are both cell types needed simultaneously? Is one cell type does one cell type need to act first before the other one occurs? And so we ask these questions. I mean, this is unpublished data, so not quite as vetted, not vetted like the other data slides that I showed. But I think it's helpful when we're thinking about the pathogenesis of the disease. So if you take activated CD4 T cells from an AA mouse and inject those into recipient mice, and then deplete those mice of CD8 T cells. So you're asking whether CD4 T cells in the absence of CD8 T cells can cause disease. And we found that they could not. So if you inject in CD4 T cells and just use an antibody that doesn't deplete CD8 T cells, you get pretty robust disease. 100% of mice develop disease over the course of 6 or 7 weeks. However, if you deplete those mice of CD8 T cells, those mice are largely protected from developing AA. And so we wanted to ask the inverse question: do CD8 T cells require CD4 T cells to induce AA? So instead, we injected CD8 T cells and depleted CD4 T cells and asked the same question. And we found that both mice depleted of CD4 cells and mice that were not depleted of CD4 cells developed disease at roughly the same rate. So to just take a step back for a moment and kind of put these together in a model, we can kind of think of it in this way, where CD4 T cells, maybe they come in first and they act directly on CD8 T cells that then go on to cause disease. Or we can think of it a slightly different way, that CD4 T cells are doing something to the hair follicle to then make them more susceptible to attack by CD8 T cells. So now to go on to the other two pathways, the interferon pathway and the common gamma chain pathway, and to see how those things contribute to the pathogenesis of the disease. So interferon gamma, just to review, is a pro-inflammatory cytokine. It's known to increase MHC class I expression on cell types that express the receptor, including in hair follicles. It activates antiviral pathways, and it increases the expression of molecules like chemokines that bring in the immune system in close proximity. And interferon gamma is produced by CD4, CD8 T cells, among other cell types. And so a few years ago, this group asked if interferon gamma is critical to the development of alopecia areata. And they used a similar model, except instead they induced disease in recipient mice using grafts from an AA mice and put those onto unaffected recipient mice. And when they did that, those mice went on to develop hair loss. However, when they put the same grafts on mice that were deficient in interferon gamma, those mice were largely protected from developing the disease, telling us that interferon gamma is a critical component to the pathogenesis of AA. And then finally, to talk about the common gamma chain cytokines, this is a family of cytokines that includes IL-2, 4, 7, 9, 15, and 21. And the receptor for these cytokines are all complexes with mixed subunits, but they all share one particular subunit, this common gamma chain. As you can see here in this cartoon, all of these receptors have this blue subunit. And then the other subunit or subunits confer the specificity to that particular receptor. So the IL-2 receptor beta, for example, with the IL-2 receptor alpha, helps bind IL-2, and the IL-4 receptor helps bind IL-4, et cetera, et cetera. And the common gamma chain cytokines, they contribute to survival and maintenance of T cells. They can provide some level of co-stimulation, so they can help activate T cells when they're present. And depending on which one you're talking about, they can affect the functioning of the T cells. So I'm just going to talk really briefly about one particular common gamma chain cytokine, the IL-15 cytokine. And IL-15 has been described to be present on AA hair follicles. So if you take samples from patients with AA and stain for IL-15, you can see that it's present along the follicular epithelium, as shown here in green, in those samples from AA patients, but not normal control patients. You can also look for this IL-15RA gene or protein that serves as a sort of chaperone to tether IL-15 to the cell surface. And it is also present in hair follicles in patients with AA, but not in normal control patients. So it seems like IL-15 is present specifically in those AA patients, but not normal controls. But then the question is whether IL-15 is required for the pathogenesis of AA. So for this, the skin graft model was used. So a piece of AA skin was grafted onto recipient mice, and then the receptor was blocked with a neutralizing antibody. And when this is done, if you use a control antibody, you can see that the majority of those mice go on to develop disease. But if you block IL-15 signaling using the anti-IL-15 receptor antibody, you can largely block the emergence of disease in these mice, telling us that IL-15 seems to be critically required for the pathogenesis of AA. And I should mention the similar data has been published for IL-2 and now very recently for IL-7. But not for IL-21, which are all different gamma gamma chain cytokines. So the particular cytokine that we're talking about probably matters. And it's interesting because these two pathways, the interferon gamma pathway and the gamma gamma chain cytokine, and specifically IL-15 pathway, seem to interact with each other to a certain extent. So in this experiment, what was done is interferon gamma, along with another pro-inflammatory cytokine, TNF-alpha, was injected into the skin of the mice. And then a few days later, that skin was biopsied, and the investigators asked whether IL-15 was present on the hair follicle. And indeed, it was in those mice that had received interferon gamma and TNF-alpha, but not in those mice that had received the vehicle control. So we can step back for a second and try to put everything together now, including the T cell data and the interferon gamma and the gamma gamma chain cytokine pathway data. And so we think CD4 T cells are probably first to act. We know they're able to produce interferon gamma, and that interferon gamma can probably act on the hair follicle to increase expression of gamma gamma chain cytokines, including IL-15, chemoattractants like chemokines, like we briefly touched upon. And that can likely bring in CD8 T cells, which can also produce interferon gamma and may also reinforce this pathway in a positive feedback loop, which will eventually result in their activation and the emergence of disease. So then in thinking about these two major pathways, the gamma gamma chain cytokine pathway and the interferon pathway, as we've learned today and we've known now for some time, that these pathways all utilize JAK molecules as proximal signaling factors. And so they participate both for both ends of the spectrum. And to view it another way, this is a cartoon that was published a few years ago that looked at the follicular epithelium here on top and looked at the immune component or T cells here on bottom. As you can see here, interferon gamma is produced and then is sensed by the receptor on the follicular epithelium, which then causes upregulation of gamma gamma chain cytokines, including IL-15, which causes activation and stimulation of the immune system, which again causes more interferon gamma. And again, you get this self-reinforcing pathway that then leads to alopecia areata. And then these JAK inhibitors, depending on which one you're using and depending on the specificity, can inhibit it at the level of the immune system or at the level of the follicular epithelium or potentially at both. So just to briefly touch upon one of the patients that we saw, I didn't really highlight this, but this is one of the patients that we saw pre-JAK inhibitor. This is a 12-year-old patient that we started on a JAK inhibitor, and just a few months later, even though he had failed other therapies, you can see here that he's doing quite well, and it probably is going to continue to progress. And that's all I have. I'm happy to take any questions.
Great. Thank you so much. We have a few questions. So those talks were amazing and put a lot into context in terms of, why we're interested in JAK inhibitors. I think a lot of the group is interested in those adverse events. And one question from Dr. Petikova is about whether these adverse events are seen as part of any of the spectrums, phenotypic spectrums of patients with known disease mutations in these JAK pathways. So I don't know if either of you, has experience with that. I think certainly weight gain with leptin, But yeah, I'd love your thoughts on that.
Yeah, I mean, I think, we know these molecules are really important for, functioning of the immune system and things like that. And they're clearly immunosuppressive. I mean, I don't think they're complete knockouts or they phenocopy complete knockouts. But you do see elements of what we see with, conditional knockouts and things like that in patients getting the disease. I mean, I think a lot of the side effects for the majority of patients are mild, but they can be pretty significant in patients that do come down with some of the side effects. So I think it's it can be relatively safe, but you really have to be cautious with these medications.
Yeah, I think the only thing I'd add to that is that as you were getting to is dose matters, and that in some patients with, say, autoinflammatory diseases where you need high doses of these drugs to control symptoms, you can have more infections. And in the early trials with kidney transplants, where the patients were being treated with CellCept and steroids and a cocktail of drugs, there were a larger incidence of infection, more than we see nowadays with the currently approved drugs at the currently approved doses. But it's certainly something to think about. In terms of the FDA's concern about cardiovascular events and thromboembolism, I mean, it remains to be seen how that's going to sort of be relevant to younger populations. So again, just have to keep our eyes open.
And then this is my question, but are there things that you are worried about in terms of, younger patients getting these medicines for long periods of time with side effects? Because I think most of us have used them enough to see that short term, there aren't any really big significant, effects, especially in children. Lab values tend to be pretty stable. Sometimes we'll see weight gain, occasionally an infection, but to be honest, even herpes virus, I haven't seen very much. But what about, potential long-term, we counsel patients a lot about that. Do you worry, and what would you worry about the most?
Well, I think it kind of touches upon the conversation we were having earlier, where then, it has to do with specificity of the particular JAK inhibitor that you're using and the array of pathways that you might be inhibiting. I think these more specific ones, we're going to feel a lot more comfortable about. But, especially with the JAK2 inhibition, we start worrying about things like Dr. O'Shea mentioned earlier about, growth hormones and things like that.
The one thing that I think is worth bearing in mind, there are some cytokines that we don't know much about, out of that 57 cytokines there are a number of neurotropic cytokines that actually have been studied quite poorly. The usual cytokines that about, IL-2, etc. There are thousands of publications, but a few of these cytokines, there's really not much known. And so, again, giving these drugs to patients for a long period of time, that's why you have to do these follow-up trials. The issues of thromboembolism and this sort of thing, I think that wasn't noticed right away, and the cardiovascular effects, certainly in rheumatologic patients, is something people are thinking about a lot. But again, that's as Ali was saying, when we were first thinking about this, and I went around to a lot of drug companies, and they said, well, what if we had a JAK2 inhibitor? Most of the, talking heads at the time would have said, no, a JAK2 inhibitor, that's just not viable. You couldn't possibly, if you get a hit that inhibits JAK1, JAK2, and JAK3 or something like that, that wouldn't be a good drug. But that turned out not to be true, and it's related to dose. But it may be that some selectivity as we go forward will be preferable. And you might imagine, as we sort of predicted in 1995, that a drug that just targets JAK3 might have some advantages. But as of yet, no one has made such a drug. But, we shall see.
We have a question from Dr. Silverman. which is, what is the cytokine relationship between severe atopic dermatitis and alopecia areata? Is it related to IL-15?
And I'm not really sure what the role of IL-15 is in atopic dermatitis. I mean, other common gamma chain cytokines certainly play a role, but I'm not sure about IL-15. The relationship with atopic dermatitis and alopecia areata, I think, is certainly there, but whether there's a common pathogenesis or if it's kind of a byproduct of having atopic dermatitis, for example, atopic dermatitis, you can think of there being more inflammation in the skin, so that might predispose you to lose your immune privilege in the hair follicle, which could lead to alopecia areata, versus having common signaling pathways that are consistent between the two, I think is something that remains to be answered.
So in a way, like it or not, some of the advantages of the JAK inhibitors is that many cytokines are blocked. So for atopic derm, blocking IL-4 and IL-13 is efficacious, whereas, as you're saying, for alopecia areata, blocking IL-15 and gamma. So it's sort of, as Holly was saying, it's you're targeting multiple steps in the pathogenesis, and in a way that maybe have some utility. And again, that is one of the reasons why we all like steroids so much, is that so much of immune responses are blocked. But that's also the same reason why we have side effects as well. Remains to be seen.
Hair loss often recurs after therapy is discontinued. What is the best way to counsel patients?
Sure. I mean, when I talk to patients, I let them know that the plan right now is to keep it on long term, and that we can feel pretty confident that if they stop using a JAK inhibitor, that they will lose their hair. And this is different than what's been shown in the animal models, where in animal models, especially the C3H model, if it's been treated with a JAK inhibitor, even a topical JAK inhibitor, for a short amount of time, and then you remove the JAK inhibitor, they have kind of a long-term durable effect. And that's not really what we see, as the question kind of alludes to, what we see in people. And whether there's, a time frame, maybe, I don't know what the longest patient on a JAK inhibitor, how long they've been on it for, but maybe if you've been on it for 10 years and then you take off the JAK inhibitor, maybe that's enough time to replicate what we see in the mouse. I mean, I think it's largely unknown. So when I counsel patients, I should say that there's really no end in sight. It's just like other medications. It only works if you take it.
So to your point, Ali, JAK inhibitors have been on the market now for about a decade, and there are patients who've been on JAK inhibitors for nearly that time. But people have done trials with rheumatoid arthritis patients where they take off biologics, withdraw and see what proportion of patients actually are in durable remissions. Those trials haven't been done on patients with JAK inhibitors yet. That probably will be done. But again, that would be a case where, again, I'd make a pitch for academic labs that the drug companies, are less inclined to think of this as a priority, whereas this is where academic labs are key. And you might even imagine, as I was making a pitch before, that if you've got somebody into remission, on a JAK inhibitor or something, and then there was a decent drug that targeted IL-15 or something, and Ali, whatever your favorite cytokine would be, you might imagine long term, once we got patients into remission, you could treat them with another drug that had a more narrow spectrum. But all that's going to be up to academic labs to do.
Yeah, I certainly think off-label, a lot of people are trying that, right, with getting patients in remission with tofacitinib and then trying Dupixent or something else after, with obviously variable success.
Yeah, I mean, I think, just to echo what's been said, I think it's interesting. I guess it's because alopecia areata can wax and wane, but I think we don't tend to ask this question about other chronic skin disease like psoriasis or atopic dermatitis. Like, we just assume that these people are going to continue. So, to me, alopecia areata is a chronic disease that's likely going to require chronic therapy. So that's what I talk about to patients. That, like, we're looking at this at least for the foreseeable future. But, is it possible that at some point, quieting this inflammation for X amount of time could change the natural history? Or, maybe, these people who do kind of go up and down, like, I think over time we will have more of an idea of, like, are there subsets of patients who may be able to dose reduce more successfully, or, is there a period of time that's preferable before you think about tapering? I mean, just anecdotally, like, we have a handful of patients who have stopped therapy for a variety of reasons who actually have maintained regrowth. And I think there will be some data from the ongoing clinical trials where, people, they do kind of a washout and they'll look at recapture. So there'll be some more systematic data, but for sure, I think it will be interesting. And again, like, look at the biologics for psoriasis, like, we're getting more and more targeted over time. So probably, if it's not this drug, maybe you'll be on something else, but the side effect profile would be more favorable.
But any speculation about how to reestablish the immune privilege around the hair follicles? So that's a huge question.
That's a really great question. And I think, what are those factors or guardians of immune privilege, and what are they in vivo, and what are the important factors there under normal circumstances? And it's largely unknown. I mean, there's a good number of candidates that we think are contributing, but it's really anyone's guess as to what might be largely responsible, or if it's kind of by committee that a good number of factors need to be present in order for that to be maintained.
Yeah, thank you both very much for taking time today to present the wonderful lectures and then give like great answers to these questions. And our next series is on the clinical trials. So we hope people will come back to listen to Dr. Sinclair talking about the clinical trials for alopecia areata.
A very big thank you to our presenters this evening, Dr. Ali Jabbari and Dr. John O'Shea. Thank you for those wonderful presentations. I'd also like to thank our program directors, Dr. Leslie Costello-Socio and Dr. Britt Craiglow.